The management of asthma is a bread and butter topic for medical school exams, so this is a whistle-stop tour of what you need to keep in mind. My name is Jonathan, and this is Management of Chronic Asthma in Adults for United Hospitals. Here's a rough guide so you can skip around as you like. As per usual, we'll base this off a patient I summoned through magic. He's presented to us at the GP surgery with a worsening dry cough and difficulty breathing. This has developed over 4 months, starting with a cold in the winter. He had these respiratory symptoms that didn't go away with his coryzal or common cold features that he had at the time. Our concern here is respiratory, so while the dreaded London air isn't likely to be helping matters, neither the history nor the examination are very exciting. Though there's something missing for what we're suspecting. A fairly low peak flow for an otherwise healthy young man, unless he's unfortunately vertically challenged. So as a GP, you should now have a knee-jerk reaction where you pelt the poor fellow with inhalers until he leaves you alone. Now, what are we looking for in an asthma presentation? Well, I've been barred from talking about the dramatic option, so in this case, gradual development of difficulty breathing and/or a dry cough, especially with this diurnal variation where symptoms are worse or perhaps only present at night or in the early morning. Almost invariably, that's what you'll see in your exams, although they will want to hear some differentials. The other thing you'll always want to explore is what might be triggering their symptoms. Did this chap just move into London? Is his new workplace adjacent to a big construction site and he's getting a lot of dust and such through the window? One thing I've seen both in patients and myself is that cycling in London without a mask is a guaranteed way to give yourself respiratory signs. Hopefully in an asthma case you'll have a solid idea from a history of presenting complaint. The past medical history is really just for context. Do they look very atopic, which would back up your asthma suspicions? Or perhaps have a psychiatric history that might lead you towards vocal cord dysfunction? Do they have any conditions, perhaps glaucoma or high blood pressure, where their medications might interfere with your asthma management? Do they have any existing lung problems that might make the situation more complicated? With the family history, you're really just focused on lung problems and perhaps any additional atopy in the picture. Regarding the social history, as with any good respiratory history, you want to find out what's going into your patient's lungs. He's a little old to be hiding a Lego brick in his trachea, perhaps, but he's the perfect demographic for all sorts of other bad behavior. You would do well to remember smoking and drugs for every patient, including second-hand smoke. Double down on environmental exposures here, such as pets or unseemly living conditions like mold on the walls, and of course, you should always touch on the general state of their life. Hopefully you explored the impact their symptoms are having back in your HPC, but always flesh that out in case there's more going on. Your examination will focus on the cardiorespiratory exam with a peak flow measurement. If you're pushed for time, prioritize. In a fresh presentation, you're less worried about characterizing fine tremors. If it wasn't flagged in the history, you won't be overly concerned about their JVP or blood pressure. Focus on general breathing function, the airway, chest movements and breath sounds. A quick look up their nostrils is helpful, whether it's with a speculum or an otoscope. Regarding peak flow, do be sure you're confident with the technique and that you first demonstrate and coach them properly. There's a few situations where you're just going to have to bring in the big guns and maybe a consultant. Occupational asthma is where their symptoms only occur when they're at work. Non-responders we'll come on to properly in a moment. Systemic features should always worry you for infections and malignancy, or funky autoimmune syndromes. If they've got other findings on examination, you'll want to revisit your differential diagnoses. If our gentleman was an older smoker, for example, and had even, fine sort of crackles, you might want to think of interstitial lung diseases. Whether you've narrowed it down or not, in most of these cases you're still probably going to want to refer them on. The question is just whether you're going to go for a 2-week wait or not. Friendly reminder here that asthma is a very funky disease process. The basic pathophysiology of reactive airways and inflammation seems straightforward enough, but you didn't go into medicine for an easy life. There's a lot of variation within asthma, and there's no hard and fast rule on how to define it, so keep other differentials in mind in case your patient isn't doing too well with your management plan. And don't forget the peak flow diary. It's a great diagnostic resource to see how they respond to management, and to help them know when to come and see you. This is a quick outline of the famous asthma management ladder. Unless you have a better differential in mind, this is where all your asthma-ish patients will start. Salbutamol and either beclometazone or fluticasone for 6 weeks, with a good chunk of time on that first day dedicated to teaching technique, either with you or a nurse. Remember, spacers aren't just for children, and can make a massive difference to efficacy. You will want them to come to you for review 4 to 6 weeks after any change to their medication, including this first trial, with their peak flow diary in hand. It's an important relationship to cultivate with them going forwards, to help them not only stay in control of their asthma, if that's what they have, but also to feel in control, or empowered, as the kids like to say these days. Of course, they should also come to see you if they find themselves needing to use their rescue inhaler 3 or more times in the week, or if they have a significant attack. I'm sorry, I'm not talking about them. Though there are plenty of barn door presentations to go around, if they have a chronic cough with recurrent infections, send them for that high-resolution CT scan first and rule out bronchiectasis. If they're a little older with some questionable workplace exposures, send them for spirometry and an X-ray. Don't miss something bad because you wanted the easy diagnosis, but always know why you're doing what you do. Just remember that if you are going to send them to physiology, they can't be loaded with the medication already. It's really all on the screen. Your first review is an excellent chance to review them with some solid evidence on reversibility, and see how well you did in the last consultation. If their technique is poor, you and the nurse had better put some more time in. There are 2 ways of going about the opening salvo of asthma management. Trust your patient with separate relievers and preventers to get a more accurate picture of what they need, or cynically give them a combined inhaler so that they'll at least get some preventer when they reach for it. MARTs can be useful to reduce inhaler burden if they're on SABA, LABA and ICS, but unless you're worried about concordance, you're unlikely to remove the control and monitoring power of a separate SABA. If you have them on a MART, there's little use doubling up on LABAs, but otherwise this is where they come into play. If you've got your doubts on the diagnosis, you'll want to tie those up before going further. Potentially 4 drugs now, so that's spicy. You can bin the LABA if they've had no benefit, though again this is getting late in the day, so if you haven't sent them for full lung function testing and a chest x-ray, and they've yet to benefit from their treatment, you're going to need to have a serious talk with yourself. And the patient. This is where you might increase their steroid dose. This is above your pay grade, unless you're a consultant, in which case this video is below your pay grade. These are the medications, roughly in order, that the respiratory team might try them on. Be aware, and ensure the patient is aware, of any potential side effects and what to look out for. You should have already brought up issues like oral candida for inhaled steroids, and that they should time the doses to be before they brush their teeth, but this is where you need to be sure that they understand to look out for Cushingoid features, and the dangers of Addisonian crisis. Theophylline, for its part, has a very narrow therapeutic window, so they need to be rigid about their dosing with it, and LAMAs have broad, annoying side effects based on their autonomic actions, such as dry mouth and blurry vision. As I've touched on the steroid problem, you'll be aware that it's important to keep that dose as low as can be trusted to keep them symptom-free. That goes for oral and inhaled. Just don't be so overzealous with optimization that they lose track of what's going on because they're on a different dose every other month. Only reduce a dose, or stop a drug, after 3 months of perfect asymptomatic joy. On the topic of pregnancy, as with pretty much anything else, the priority is keeping them stable. That's especially true in pregnancy, because the worst scenario would be a big asthma attack. Question time. I'll give you 10 seconds for each question. First one. You increased a patient's inhaled corticosteroid dose 3 weeks ago. When should you next see them? You need to review a patient 4 to 6 weeks after any medication change, as soon as possible after an attack unless they're being directly reviewed by a specialist, and if they ever find themselves using their reliever 3 or more times per week. What will you do if a patient doesn't respond to short-acting beta agonist and inhaled corticosteroid therapy? You should be logging this from their peak flow diary, of course, and if they haven't been keeping up with it, you should advise them on how much harder this makes life for the both of you. But if they've not shown clinical reversibility when you were certain that they would, get a relatively objective test done. Once the drugs have washed out of their system, remember. Which of these drugs is prescribed first? I'm being a little sneaky with this one. Terbutaline is the alternative SABA, so it is a first-line drug, unless you're starting them with a MART and skipping SABAs entirely. Salmeterol is a LABA, but not the one used in MARTs, which makes it decidedly second-line, and montelukast as an LTRA is third-line. As a quick recap, your progression of drugs is SABA and ICS, or a MART, which is LABA and ICS, followed by LABA, followed by LTRA, followed by writing a letter to a respiratory colleague. Your whole management plan is effectively worthless if you don't coach them properly on technique, which is ultimately your responsibility, though there is typically a nurse who can help by taking more time with them. Spacers are highly useful for everybody. The peak flow diary is sometimes the best monitoring tool, in spite of its complete lack of cost, but you should not hesitate to make use of spirometry, phenotesting, radiography, and the labs when they might be of diagnostic use. Take care around steroids. You want to minimize the dose of any and all drugs, especially these ones, but your priority is the patient's stability and well-being. Don't try to wean or remove a drug without 3 months of no symptoms whatsoever. And remember the 3 times to review. 4 to 6 weeks after a medication change, ASAP after an asthma attack, and any time they've needed their reliever 3 or more times in a week. If you'd like to see more about asthma, these are good places to start. Thank you for watching, and I hope you found it useful. Green and gold.